members that would like to make an announcement, first of all? Okay, Autumn and Heidi?
Tomorrow, in Main Station, we're going to be
Wait. I don't think they can hear you because they're talking.
Sorry, girl.
And multitasking is great, but I know if I'm busy in another lane, I'm not listening. So, okay, sorry.
Tomorrow at 4 p.m. at Main Stage Theater, we're going to be hosting Dr. Phil Liv. He's a professor at NYU. He's going to be discussing the LGBTQ plus health disparities and social inequalities. It'd be great if you can come. I know some people have been clinical, but if you have days, that would be great if you guys could cover your weekends. Also, just a reminder, the 17th, it's next Monday, we have our nursing club meeting at 1:30, and it'll be in either room 206 or in Teams. So if anybody's interested, please show up, or please come see myself, Heidi, Alexis.
Everybody knows Heidi? Okay. All right, I just want to make sure.
Thank you.
Okay, you're welcome.
Thank you.
You're welcome. Perfect. Alrighty, so my name, if anybody doesn't know me, is Professor Leach, Felicia Pepper Leach. Okay, I think I've seen everybody, we have seen all of you in on-campus clinical. I've worked with Professor Parada, right, on on-campus clinical, so I think all of us have gone through. And I just want to say there is a sign-in sheet here. And if this isn't somebody's way of sitting, just move it and we'll go someplace, we'll put it someplace else. So if you want to sit here, that's fine, but we'll go someplace else. So what I'm doing today, and basically I'm kind of laying the foundation. I'm going to keep my mask off while I'm up here, not close to anybody. But what we're going to do is we're going to lay the foundation for the GI system, because I'll be back. We're talking about peptic ulcer disease today, PUD, the GI bleed, which is a complication of PUD. I'll be talking about diverticulosis and itis. I believe I'm pancreatitis as well. And then other people will come in with hepatitis, ulcerative colitis versus Crohn's. So we're hitting the whole GI system today, okay? Not today. We're laying the foundation for today. So my first thing is I have a picture here. I'm not an artist. So if you look at the picture, what do I want you to know or think about if you're in the GI system, right? It starts at the mouth and it ends, you know where, at the other end, all right? That's where we have the GI system. So it's everything between here and there, all right? So if you're doing an assessment, I have something here, diet tolerance, okay? Diet tolerance, that means you're thinking about what? Food coming into your mouth, right? Or food coming into your mouth. So what are you always assessing? Can you tolerate the food? What does it mean if you can't tolerate the food? You're feeling nauseous, okay? So don't forget to always assess for nauseous, vomiting, and diarrhea, although we have stuff already written down for bowels, right? You know, everybody has hit the bowels, the abdomen. There you go. Look at that. Isn't that perfect? Okay? So here, the ability to tolerate food. You know, what have you been eating? Are you having any feelings of nausea? Are you vomiting? Right? You know, how's that, you know, like, is there an aversion to food, or does food help you? So you're always thinking that way. Here, starts here, ends there. You go down, abdominal, look at that abdomen, right? So we did bowel sounds, palpate, here we go, right here. So I'm just gonna mark all the abdomen, okay? All right, we're abdomen, right? And then you wanna know you wanna know about pain, perfect. Does it get worse with eating, or does food help it? Remember this part, taking the food in? Right? So you're always thinking about where's the GI system located, right? And then we've got some bowel movement questions. Okay, I'm not doing the arrows or the stars in any order. There's no significance with a check mark versus a star. It's just, I'm just trying to put them, kind of clump them together, right? Right? So you're always assessing, if you kind of do it in top to bottom. Where's my gingerbread man? I know he's in the closet, and I should have brought him downstairs. But my gingerbread man, you're kind of thinking top to bottom. So even though, here's my gingerbread man, mouth, all right? Nausea, vomiting, diarrhea, any kind of nausea. Are you able to tolerate the food? What are you taking in? Does food make it better or worse? With anything, right? Are you eating? When was your last meal? You can ask all sorts of questions around the eating part. All right, and then you're going down in difficulty. You can even think like difficulty swallowing. You can talk about, do you have your teeth in? Right? Hospital, right? Do they chew with their teeth? You get all sorts of big nutritional questions. We're focusing in just on that stomach problems, okay? Nausea, vomiting, or diarrhea. Let me listen to your belly. Do you have any pain anywhere? And how have your bowels been? Okay, what's the color of them? How often? Do you see any blood or dark and tarry stools? Okay, let me guaiac them. I'm going to guaiac them, so that's a good diagnostic. Here we go, right there. A guaiac test, because you're checking for bleeding or occult bleeding. So do you see how you're focusing in and your diagnostics are very specific? Your GI system, here's the mouth. We're starting here. Here's the anal opening. Okay, so again, I'm not doing the whole digestive system, but if we're talking about what part, we'll start at the top. Here's your esophagus. Okay, here's the esophagus. What's this sphincter or this part at the end of the esophagus, at the beginning of the stomach? What's that called?
The pyloric sphincter.
Okay.
Pyloric down below.
Pyloric is here.
There you go.
Okay? So you hear these words, the LES, lower esophageal, the base of the esophagus, sphincter. The pylorus is at the junction of the stomach into this duodenum. Remember, the first part is the duodenum of the small intestines. And again, I'm not an artist, although who's my artist here when I'm in my room? Okay, if you want to draw us a nice, draw a picture after the test. That's what I'm saying in my room. Okay, all right. GI system, all right, all right, so we have a pyloric, we're going into the duodenum, and then there's the rest of the GI, the rest of the small intestines. Here's a valve here that separates the small from the large. It starts with an I.
Ileocecal valve.
Ileocecal valve. It goes up the large intestine, so it's called
Ascending.
ascending, transverse,
Descending.
descending,
Sigmoid. The
sigmoid, rectum, anal opening. Now, I'm not talking about this part today, but I will be talking about this part of the bowel on Thursday, I think, for osis and itis, diverticulosis and itis. So it's good to know a little anatomy. No different than you, Patrick, think about cardiac blood flow, right? Okay, that's all I want to talk about. And we'll go back to my lovely picture to see when we talk about different things, all right? We're talking today about PUD, peptic ulcer disease. Now, as much as we don't ever want to hear you call that hamburger or hot dog PUD, okay? When we're talking about renal studies, it is very acceptable to talk about peptic ulcer disease as PUD, okay? So I'm just clarifying that. All right, so I did voice over my PowerPoint. You heard my voice, so now we're just gonna do a little discussion, right? So you wrote down, and I love those concept maps. That first page of your clue concept map, that to me, I follow the other concept map, which has all the same information on it. Risk factors, diagnostics, and that's what we're gonna just be aware of today. Okay, is just thinking about what's going on. There's a couple of slides I do need to go over with you to make sure that you have them, okay? But as far as a focused GI assessment, do you want to add anything else for any type of assessment? So if you have any kind of reflux, so here's food related. When does it occur? And what could you say to make, what else can you, so I have it, so I say, yes, I have it. What can you say? Okay, so you're going to further explore when does it happen, okay? It happens after I eat at night, my evening meal. What time is your evening meal? Okay, I get home late, I eat, it's 8 o'clock at night.
Well, that could be part of your reflux. A lot of times you eat later in the day and you go to sleep, you're not allowing your body the physics to, kind of process.
Correct. So what should I do?
Try to eat earlier.
I can't eat earlier.
Try to eat a smaller meal at night and eat more during the middle of the day or at the time you have work.
So it could be if you had reflux, you could have some small, frequent meals, right? That could be it. And so GERD, so that's what we're talking about, GERD here, gastroesophageal reflux disease, right? That could be your assessment. Do you have a history of GERD or reflux disease? And it's no different than you can ask, and I'm gonna kind of hold this here, past medical history of celiac and IBS. I associate that, so I'm gonna put this in parentheses here. I'm gonna associate this, is it with the stomach? This IBS and celiac disease? Is it a problem with the stomach? It's a problem with the intestines. Okay, it's a problem with the intestines. It's a problem with the motility. All right, so there's definitely a pathological component to the celiac disease. There's no pathology with irritable bowel syndrome. Okay. All right, so I'm going to just kind of put this on hold here because we're just kind of focusing in on if the person comes in and they find out that they have PUD. Do people usually have do they ever? When do they go to the doctors complaining about what? Pain. Here we go. So, big thing is pain. Now this one, I'm going to star it. So our signs and symptoms, I kind of go along with here. Signs and symptoms are clinical manifestations. The big classic sign is pain. Okay? That's your biggest classic sign. All right? So, what do we know about pain? We know about the food we ate, right? Anything else? What else are you going to ask?
What type of?
When did it start? Sure, that PQRST, what makes it, do I have to write all that down? Do I need to do that? No. I mean, I think as first-year students, that's your biggest component of your first-year students, right? It was all pain-related, right? Everybody has pain. Everybody has pain. Now we need to find out a little bit more about that and what can it lead to. All right, location. Right? So where's the location? That's the biggest thing, signs and symptoms of pain, working that all up. Where are these, and I'm just kind of going all over the place. I'm not going all over, I'm just trying to bring it back. Where are these PUD? Where can it happen?
Anywhere within the GI tract.
What is it? Left upper quadrant. So I'm thinking left upper quadrant. So there's one, left upper quadrant. Where else? Where can these ulcerations occur? That's maybe direction. Where can peptic ulcer disease occur? Oh, so again, anywhere through the GI system. Right? So they can be in the esophagus, and I'm going to put this ulcerations, right? They can occur in the esophagus. Are we going to talk about that today? No, because that's going to be up to Professor Parada, dealing with the liver, okay? So where can they occur? Where's peptic? Ulcerations can occur anywhere through the GI system. You can get an ulceration down in the intestines, but where's peptic ulcer? Where are we dealing with it? In the duodenum, and then where else? Gastric, stomach. Stomach and duodenum, right? Can they occur lower? Yes. Yep, can they occur lower? Of course. So ulcerations anywhere. All right? So peptic ulcer, gastric, and duodenum. Pain, right? Big symptom there. What else can be a symptom of peptic ulcer disease? Somebody say.
Heartburn,
Heartburn, so there's that bird.
exploding.
Okay, there's that bird, yeah, indigestion.
I don't know if it's up there, those, they call it that coffee ground, emesis, when,
Coughing,
the coffee ground.
the coffee ground vomitus. That would be, here we go. Where am I gonna put that one? If I see that one, where should I put it next to?
The complication, but it's also a sign.
Okay, what is that, coffee, somebody else, coffee ground vomitus on this side, I'm gonna come this way. Coffee ground vomitus, what does that tell you? There's some bleeding mixed in with food. Okay. So here's the GI bleed this way, right? This way, coffee ground vomitus. What other kind of GI bleed can I see coming up here? What color could it be? Bright red blood, okay? So here's our upper. If it's a slow bleed and the person comes into the doctor's office and say, I just don't feel good, don't feel great, I don't know what's wrong, and you're gonna ask, do you have any pain anywhere? Not really, and I'm gonna go down that whole assessment. Any pain, any trouble with food? Not really. I just don't feel really great. Okay? I feel tired. I'm weak. I just don't feel myself. All right? So out of all of this, we're gonna palpate the belly for any kind of tenderness. No, we're gonna listen to bowel sounds. Right? And maybe they send them to the lab for a stool guaiac, and it comes back positive. So what do we know? That this what? It's a slow GI bleed, because it's bleeding from it's bleeding from somewhere, but it's traveling through the whole intestine. Okay, so what do we call that stool if it's dark?
Melon?
We can have melena, okay? What's the difference between these two?
Yeah.
Okay, all right. Can everybody hear them?
No.
Wait, I'll get you a mic.
So the bottom one is the bright red, and melon is dark and tart.
So a bright red clot, a clump of mucus that looks bright red or maroon light, right? Okay. Okay, so signs and symptoms, pain, low H and H. And we don't know, we don't come in saying we have a low H and H. They might just come in saying I'm feeling weak and tired, right? Yeah? What else can be? Just do that PowerPoint somewhere. Anybody care to look at that PowerPoint and see what slide is it? You want to tell them? Everybody hear that?
Feeling of fullness, even though you didn't eat in a while.
So that early satiation, feeling of fullness. I haven't eaten in a while, but I just can't eat. I'm not my normal self, right? I'm not my normal self. What slide is that? Anyway?
5:35.
35, right? That far in?
It could also be slide 6.
Yeah. 35 is way too far.
6. Slide 6.
Okay. We're gonna try to pull this all together without, I'm hoping that you listen. I mean, I know it was a lovely weekend, but I'm hoping that you were able to listen to my voice over the whole, weekend. All right. So I want to capture key points, all right? Do I need to talk about, like, where is it located, right? You know where it's located, lower peptic ulcer disease, gastric or duodenal. Risk factors, we haven't talked about risk factors yet, but we talked about that focused GI assessment, but we've talked about signs and symptoms. That silent GI bleed, and when do they happen when there's silent GI bleeds? They just occur. How does the person develop a GI bleed? I showed you a picture of some people all over the place. So what's that person? The person that takes a lot of what? NSAIDs. Okay? NSAIDs. What else do they take? Who else is at risk?
People that
Like what other meds cause some bleeding?
corticosteroids, Plavix, steroids, Cytotec.
Steroids, corticosteroids. So what kind of person takes aspirin prophylactically on a regular basis? A cardiac, right? So if that person's on something that causes some sort of GI irritation, can they stop that? No stopping it. What do you tell them to do?
Take it on.
I have to take my aspirin. I have to take my prednisone. I have to take those corticosteroids.
Make sure you take it on a full stomach.
Take your food. I like your NG suctioning, but I'm gonna put this in parentheses down the road, because we're gonna associate it with something else, okay? All with peptic ulcer disease, okay? But the complication is GI bleed. All right. So we have control, do we have control over age or genetics? No control, so non-modifiable. We really have no control over that. Okay, so yes, you're more prone to ulcerations, but never, we have no control over that. It is, we are who we are DNA-wise, all right? What is it? Type O. So just the research has shown that if you are a type O blood type, that you are more susceptible to having one. Can we do anything with that information? No. Okay, we can't do anything with that except take good care of ourselves, but we need to take good care of ourselves for everything, right? Okay. Well, let's go back to the risk factors here. Right, meds. We have non-modifiable ones. Look at this star next to the H. pylori. Big risk factor. How do we treat H? If you know you have H. pylori, first of all, how do you know you have it?
breast test, urea breast test.
What do you have?
A urea breath test?
A urea breath test. Is that the first? How do I know I have H. pylori?
You become symptomatic.
Symptomatic. What's your symptoms?
Pain.
Pain. Where's it located? Okay. Location, location, location. Where's the pain? I have belly pain. I have belly pain. So that's what's going to drive you to the hospital or to your doctors. Are you going to say, I think I have H. pylori? No, but I have pain. Where is it located? Okay, that's your next question. Is that PQRST? I have pain. Where is it? Okay, let me just get my microphone up there. My mask on as I go amongst all of you people here. I'm trying to keep myself as good as possible at home. Because
Persistent bad breath as well.
okay, so if I have persistent bad breath, you may have some bad breath, but there's people that I know. Is that the first thing that you say when people have bad breath? No. But that's one of the symptoms, okay? So, when somebody has bad breath, I say, why don't you brush your teeth last? You want mint. Right? And there's, how about, I think of diabetics, you know, with that bad acetone type of, it smells breath. But where's that first thing going to happen? You're going to have abdominal pain. Location, location, location. So where's the abdominal pain going to be if it's in the stomach or the duodenum? Describe this. Describe here. Of course, you can't feel me, so here's the epigastric. This is epigastric pain. So where does epigastric pain start from? It starts, okay, here's my breastbone. So the bottom of my breastbone to your belly button. There you go. There's your epigastric pain. All right, so there's the PQRST. Where is it located? Show me. Does it radiate anywhere? Where does sometimes this pain radiate to? The back. Okay, all those PQRST. This is probably a number. Whenever you're doing pain, where does it radiate to? Show me where it's located. When does it happen? Okay? The bad breath of the urea, so the urea breath. So going back, how do you know you have H? You know, what are the risk factors for H. pylori? How do you get H. pylori? Food contamination, living in small and close quarters, sharing your apples, your drinks, your saliva, okay, with people, contaminated food, hygiene.
How do they get it?
How do they get it? How do you get it?
Somebody else.
Sure, it's sharing, sharing. Okay, it's just sharing. Somebody has done it, right? Okay. Keep going, H. pylori. How do you get H. How do you treat H. pylori? So H. pylori is, and how do you know? Somebody said H. pylori breath test. Okay, it's not only antibiotics, but we're treating it with a combination PPIs, H2RAs, and antacids. We're using all of that combination. All right? So IV antibiotics, what do? What do you know about IV antibiotics? They're prescribed for what, 1 day? It's a long time. It's a longer time, meaning how long? Is it 1 week, 2 weeks, 5 months?
I don't know.
It's usually what, 7 to 14 days, right? So there's a duration of time. I feel better after 5 days. What do you need to tell that person?
Finish the whole
Take the whole thing. Taking antibiotics makes me feel like what? What kind of side effects do antibiotics have?
Diarrhea.
Nausea, vomiting, diarrhea. Right? I need to take the antibiotics. I don't want to take them. It gives me indigestion. It gives me an uncomfortable feeling. What do you tell the person?
Take it with food.
Take it with meals. You have to take it with meals. It is gastric irritating. So anytime you have any med that's gastric irritating, because of the side effect, you want to take it with meals.
What about taking,
Okay?
taking like a probiotic also to prevent C. diff?
Probiotic definitely for C. diff. Okay? So when I think of probiotics, it happens in the intestines. It has that good flora, that good intestinal flora, avoiding C. diff. Okay? All right. So here we have, again, how does stress and smoking. Now your DSM module talks a lot about reducing stress. If you've looked at those NCLEX and DSM module questions, I do go through them, and they really emphasize, reducing your stress. And stress is, do we all have stress here? Do we all have peptic ulcer disease? Because, no, we don't. Okay, so stress plays into it, but how do you tell somebody, I'm so stressed? I'm stressed. I mean, like every day I wake up, it's like, oh my God, I'm all over the place, right? And you're stressed because somebody's ill at home, and you're stressed because you have to take a test, and you're stressed because, you got into a fight with your boyfriend, or husband, or spouse. Okay, so you're stressed because you're leaving late for work or school. You're stressed for whatever reason. So you've got to find a way to manage your stress. And we could talk about stress management ad nauseum, like, and talk to people, talk to your friends. What do you do when I'm so overwhelmed I can't manage it anymore? Okay, I feel as though I'm gonna crack, or, you get to a breaking point. What's the tipping point? So I'm not asking for answers right now, but think about it. You need somebody, a support system. You need somebody to vocalize your thoughts to. Okay, and you can only do one thing at a time, and do it well. Right? So the DSM does talk about stress a lot, or reducing the stress. All right, diagnosing it, the breath test. But what's your gold standard? The endoscopy. This is non-invasive, this is invasive, right? So non-invasive, invasive, endoscopy. And endoscopy with biopsy. Because what do we do a biopsy for? For pathology. The pathology is going to tell me, right here, it's a risk for gastric cancer. Okay, so whenever you have PUD, you're always at risk for. All right, so, and then you do pathology. Do you have H. pylori or not? So it's another way of identifying H. pylori. Come in, pain, okay, we do all those interventions for pain. are we worried about whenever we're vomiting copious amounts?
Potassium.
Okay, so. Okay, when we lose fluid, how does it affect, what does fluid affect? Anything else when you do this for your initial assessment? You get dehydrated when you have fluid loss, right? So what does it affect on your vital signs? Okay? So you're always hypovolemic shock. Does that make sense? Dehydrated, loss of fluid, vomiting here, losing fluid there. Good? It makes sense to you? Just trying to find here. Here we go. Here. Now I'm putting stars. Yes. Okay. And tissue integrity with inflammation. I'm trying to patient problem. Where's the tissue integrity? Where are we thinking about tissue integrity?
Lining of the
stomach
stomach.
or your GI tract.
Okay, so the lining of the tissue in the GI tract that's ulcerated, so it's going down through different layers. So what would you see when it gets down to the blood vessels? It's eroding the blood vessels. What are we going to see? Blood, so bleeding. Okay, so bleeding. We're not going to actually see the tissue integrity in your stomach or GI tract, but we might have some bleeding. The bleeding is going to lead to what? If we have a ulceration, so you're going down through the tissue integrity, all right? So with inflammation, you go right down, all the way down, we have some, what are you going to experience? Pain and some sort of bleeding. If we're bleeding here or here, what are we losing? Volume, right? So we're doing volume loss. So tissue integrity, I try to see it. Inflammation is swelling, all right? You think you might be bloated, but you're not swollen. Does that make sense? Yeah. So I'm going to kind of hold off on these two right now. We know we have inflammation and we have destruction of tissue when you have GI. And you have
Pain, right?
biggest thing is pain, and you're always thinking about fluid loss. You're always worried about, with too much fluid loss, we can go into hypovolemic shock. If we have fluid loss that's blood, we're always worried about a GI bleed, some sort of GI bleed. Fluid loss, and it's bleeding, whether it's vomit or through stool.
Is acid-base balance ever an issue?
Acid-base balance. Not really. Do you know what I'm saying? You can have, you're vomiting, you're losing potassium, you're losing fluid. That's your biggest thing. So you're losing acid as well, okay? So we treat it, we're losing acid. Okay, we're losing HCl, okay? Hydrochloric acid. Yes, we can go into, yeah, acidosis, metabolic acidosis. But
Alkalosis, if you lose.
acidosis, alkalosis, yeah, we're not going that route, okay? We're identifying, what are you gonna say? You have metabolic alkalosis? That's our biggest problem? Yes, we know why it's there, okay? All right. Let's just talk about the meds. And then I think it should wrap it up for you. I will go through to make sure we're all on the same page of this GI PowerPoint with you. But let's just talk about the meds. And I'm going to save the GIs, the NG suctioning. Let's just go back to NG suctioning. Where would I put that with if I talked about here? If you're vomiting copiously, right, and you have some bleeding, you might do some, you'll look for, where's that NG suction? GI bleed. Like vomiting, too much, you can't stop it, GI bleed, upper, okay, GI bleed. So interventions there, NGs to suction, right? Let's just talk about the meds here. We talk about PPIs, and I'm just gonna put this here, because do we need stool softeners for PUD?
No.
I mean, you might, because if somebody's constipated, we're gonna try to do more natural ways, okay? So I'm gonna erase that stool softeners, because for meds of choice for treating PUD, it's not gonna be a stool softener. All right? I'm gonna leave sucralfate up there. What are we gonna do with sodium bicarb?
Neutralize the acid.
You're gonna do what?
Neutralize acid if you have like acid reflux.
Okay, so give me an example of that.
Pepsid.
So is that, what category is that one fall into?
Antacid.
Pepsid is not an antacid,
Histamine.
but this one could be, this one is an antacid. Okay? So we have sodium bicarb as an antacid, so that's another category.
But if it's reachable, then it's
What about these
But-
things?
that one. That's what
That's
that's
protonic.
Okay, how do I know them with the, I think I gave you a little hint on them. The praise, not the prazols, tizines, is that what this means? Okay. What do we know about PPIs? Our biggest one is protonics, pantoprazole. That's our drug of choice, a PPI. And you'll find all of the other ones with the prazoles. You have to give them on an empty stomach. Key. Okay, key. So I'm gonna do them right here, just so we can fill it in. Okay. Do you give them with other meds? You take them on an empty stomach, can I give every other med with it?
no alone.
Not chew it either.
You don't chew them, you don't crush them, you just swallow
Long-term use, watch out for osteoporosis as a side effect, if you're on it for 5-10 years.
them. So long-term here, osteo, okay, so it's decreased calcium. So if you're on this for long-term, you need to monitor calcium levels. Okay. What else does it lower? Here,
Magnesium.
magnesium. So it lowers magnesium. So if you have a person, if you're working as the office nurse, and you have this person on PPIs, and I bet you there's a lot of people out in the world on PPIs long-term. There are a lot of people, I'm not betting, I know. There's a lot of people that have all sorts of complications, but we have PPIs on board, or H2RAs on board. It does decrease calcium and decrease matt. There's always a risk of osteoporosis. So maybe like you could do a bone scan, okay, to kind of get a baseline for it. But these are very, very important for you to remember.
I was just gonna say, the PPIs block all three pumps, so they're more effective. H2 blocker used to be the only one that found the only one histamine, so they're kind of first line type thing, but PPI is the best.
Okay, proton pump inhibitor. It stops the production of HCl. Proton pump inhibitor. That's what the PPI stands for. Proton pump inhibitor. Whereas the H2RA receptors antagonists, what did they do? Where are they located? Where do you think they're located? Where's the histamine? Remember, we have histamine all over. We have histamine if we get slapped, bitten. We have histamine receptors in the, where we're talking about, stomach. Okay, so we have those histamine receptors in the stomach. Do they block all HCl production? No. They just reduce the amount of HCl production. Reduce, decrease, the arrow down, decrease HCl production. Can we use the same type of information that you use for PPIs and? Do you take them alone? Yes. Do you take them with other fluid? No. Okay. So you don't take them with other food, you take them alone. So here's two ones. So you have to really kind of think about being thoughtful. What if this person's on Synthroid? Now you haven't gotten to levothyroxine yet, but Synthroid. Have you had anything? Levothyroxine or Synthroid is take-alone med. So you have to plan out those meds. So can you give the Synthroid and the PPI together? No, take alone, take alone. So you gotta alter it. It's usually given in 30 minutes to a half an hour, okay, before meals. Take on an empty stomach. That's what that means. Take it 30 minutes to an hour before meals. Take on an empty stomach. That's the same thing, right?
Mm-hmm.
It's not confusing, is it? Just take it alone. Take it before meals. 30 minutes to an hour before meals. Same thing with the H2RAs. Okay? They don't block proton pump inhibitor. It stops the production of acid, whereas the other one just decreases the amount of acid. This one is more longevity, so 24 hours coverage, whereas the other one may be taken twice a day. So it's a little shorter duration of action.
So if, like, I had a patient who was on photonics and he was getting it at the same time as like 4 or 5 other meds.
IV? I'm doing this thinking
No,
you're saying
oral.
IVs.
Oral.
Oh, oral.
Oral photonics and several other different oral meds, all at the same time. Should that have been spaced out maybe?
That's a nursing judgment, that's correct. So if you're the nurse and you see this person's on protonics or any kind of prazole, you need to think, okay, it's ordered. You know how they order at the MAR. The doctor puts it in the pharmacy. If the pharmacy's not up to speed, you can call up the pharmacy and say, hey, we need to give this one alone. Can you change the timing of it?
Okay.
All right, that's nursing judgment. That's good. You recognize it. Pardon? IV push is IV push. IV push is into the bloodstream. So you can give that and you can give oral pills. Okay? IV protonics, can you mix it with other drugs? No, because you're looking in your folder, remember? You're looking in your Bible book of IV meds. Do you mix it with other meds? No, the only med is you mix it with normal saline if you dilute it. A solution. So thoughtfulness, judgment on the nursing part. Call the pharmacy. Sometimes at one hospital, it would make me so not upset, but like, oh, for goodness sakes. I'd call the pharmacy and say, you have levothyroxine ordered at 8 o'clock. Can you change the dosage to 6 o'clock? Oh, yeah, no problem. That's all you need to do, because you know it needs to be taken alone. Call the pharmacy. They can change the time of it. So one time a day drug. Okay? All right. Big things. Take it alone. I'm going to put it all, take it alone with empty stomach, right? What about antacids? So we have sodium, aluminum, and magnesium compounds. So milk of magnesium, sodium bicarb, all right? Okay, we have Mylanta. Okay, so you have to look at the ingredients. So when you're teaching somebody, you also want to have them read, you want to talk about teaching, read the labels. Because you want to, if you're taking an antacid and you have other history, we have sodium products and calcium products. We do have calcium products, calcium, like Tums, okay? Calcium, okay? But we have all sorts of antacids. So all these two do is block the production or decrease the production of HCl, which is the culprit. What do antacids do to the ulcer? So we have a high acid content that ate away at our HCl, ate away, caused the ulceration, okay, went down deep, it ulcerated, blood vessels, inflammation, okay, and acids. They neutralize the acid, okay? So the acid, what do you think our acid content is in our stomach? What's a really acid pH?
7.2.
Below 7.5.
Yeah, okay, yeah, it's 7, so acid is like 7.2, 7.1, so it depends on how much acid is in your stomach, right? Right, 7.2, antacid neutralize it, so you're going to increase the pH to like 7.7, 7.8, you're neutralizing it. All you need to know is neutralizing. What does that mean? It makes less acid content. Am I ever going to ask a question on what's an acid HCl? No. Neutralize. I want to know, as a nurse, when are you going to give antacids? Before meals or after meals?
After meals.
One of the other.
1 to 3 hours after meal.
Can you pop a Tums frequently? Well, ladies, anybody have indigestion, stress? You feel like, oh my God, my stomach is feeling, I have a little discomfort here, I keep burping,
Yeah.
okay? Can you pop a Tums
Yeah.
frequently? Yeah. Okay, does it last long? Not really. We can use it prophylactically, so you're giving it after meals. Can you follow it with some water?
Yeah.
Okay, if you don't like the taste, I kind of like candies, right? Right, Tums, they come in different colors. Rollies are gross, they taste chalky. Okay, has anybody not had a Tums? We're all stressed. Oh, no stress.
No, I just have
Oh.
No, I have stress, trust me.
No, but, right, I need a Tums because I feel awful in my stomach. My stomach's bothering me right here. This is what my daughter would say. Where's the pain? Right here. Yeah, it's like a little indigestion there. Why? What did you do?
So is there any consequence to taking Tums like that very frequently?
Is there any, the question is, any consequences to taking too much Tums?
Just like every day, all day.
Well, I thought last year, I heard they can't take them too much because it would cause alkalosis.
Okay.
That was a.
If I was, are you concerned, so, let's just rephrase the question. How much is too much?
Probably like 4.
Every day, constant.
So, you know, you have a pack of Rolaids, maybe, I don't know how many are in the pack, they come in a little round thing of Rolaids, I used to have them in my desk, okay? A pack of Rolaids, and if you go through them every day, and your friend tells you, I go through a pack of Rolaids every day, what are you going to say? Okay, but as good nurses, what are you going to say?
You need to go to a doctor to have that checked.
That's a lot. Don't you think that's a lot? And
Tell
then,
your diet.
then what are you gonna ask that person?
What you've been eating.
What do you take for it? Why do you take them? I wanna know why you're taking them. They just like taste good or what? I mean, I had a little person take a whole bunch of aspirin because there are 81 milligrams of aspirin, baby aspirin, St. Joseph's baby aspirin was on the counter at their home. And they took them, they taste so good, they're orange flavored. So why do you take them? Do you know what I'm saying? So you know, like, why do you take them? Because I have stress? No, they're not gonna say that because, they're not gonna say they take them because they have stress. They're gonna take them because what do you think they're gonna say? I have belly pain, I have indigestion, I have a lot of burping. I just feel uncomfortable in my belly. My belly feels bloated. Okay, as the good nurse that you are, you're gonna try to solve that mystery. That sounds, are you taking anything else? Because you think about other meds. You're taking, oh, they put me on a steroid. Blink, 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 right? Or I take NSAIDs because I have a knee problem and I've been running. Right? So you're investigating. So what are we doing? So how much is too much? You gotta further investigate. Yes, will it cause problems? But what did they give you for a parameter? How much, if you're eating a pack a day, we got a problem. Overuse, absolutely. Okay, so when do you take them? Does it help? What other meds are you on? So you're progressed, right? We're progressing. What other meds are you on? Always suspect the meds. Okay, so it neutralizes it. This decreases HCl production. This blocks it. Look here, empty stomach, take alone. Empty stomach, take alone. When do you take alone? What about this med? When do we do it? After meals. And how many times do you eat? 4, 5, 6, 7, 8, I don't know. That's small for meals, right? Every 3 to 4 hours. Bedtime. You're using it prophylactically. I had a patient that said, I took a swig, okay, you take the milk of magnesia bottle, right? He has indigestion. He has, depends on the type of foods he eats, how he lays down, when he last meal, on a proton pump inhibitor. I take a swig of my Lanta before bedtime on most nights. I said, why? It's prophylactic, just in case. I don't want to wake up with that indigestion. Have you been for an endoscopy? Yes. What did it show? A peptic ulcer. Where is it located? In the stomach area, in the antrum of the stomach. Okay. And he's spitting up blood, so I'm doing my assessment. And he's spitting up blood? No. Right? What do you take to help yourself? Small, frequent meals. Okay, don't go to bed on a full stomach. Head of the bed up a little bit, or head of the bed up. They use blocks under the head of the bed. sitting in the chair before you go to bed. Are you on any medications? Oh yeah, I'm on a Protonix. When do you take it? In the morning. Okay? What other meds do you take in the morning? Oh, I take Synthroid. Do you plot them out? Do you take them together? Oh God, no. So the person did good teaching, right? Whoever had this person as a nurse did, no, you don't take them together, you separate them out. Do you eat right after you take it? Oh gosh, no. Good teaching, all right? It's past 10:30, take a little break, come back, and we'll go through things, okay? Is this, okay, one more med, the super faith, okay? And that's it, come back. Nutrition as related to the nausea, the vomiting, and the diarrhea. Here's the diarrhea for the fluid and electrolyte loss there. So you're just trying to think about it. If there's I'm not talking about bowels today, but in the GI system, or maybe in the GI system, if you have problems with your bowels, you got problems with elimination. Okay? Now, elimination, this is not an issue today, okay? But you're thinking, I'm just kind of I'm going to put a little line. Okay? But today, we're talking about, infection because of H. pylori. And with any infection, there's always inflammation. And whenever you think of the word inflammation, what does it really mean? Inflammation means there's redness. There's swelling. If you have redness and swelling, you have pain, right? Redness, swelling, inflammation. Right? With inflammation, you're always thinking about white blood cell count too, right? Infection. H. pylori, so WBCs. You're just thinking, oh, where's my diagnostics here? Somewhere there's diagnostics, maybe a WBC. And I'm kind of like sad that nobody did, what's my biggest thing for any kind of assessment? What do you want to do first? That tells you so much. Please, when you think of vital signs, you're going to think of everybody. Everybody needs vital signs. It gives you a little bit of knowledge of where does this person stand. When I talk about GI bleeding, I talk about hemodynamic stability. What does that mean to you? Hemodynamic. So hemo means blood. Their blood pressure is and heart rate, they're married, are stable. What's stable? How low can you go? How high can you go? Hypoglycemic shock, right? Okay. So just kind of looking at the picture here, you saw what an ulceration was. I talked about it. It goes through several layers. How deep does it go? We don't really know how deep does it go until you get they actually visualize endoscopy, right? And do you know whether it's cancerous, malignant or not? The only diagnostic is a biopsy. For the rest of your life, you'll know, did they do a biopsy? Because that's what you really want to do. What is it? Did they do a biopsy? Because you're always worried about the big cancer. Okay, or what is it? So nothing, nothing there. I'm hoping that you could answer the objectives when you do go through these. What are you going to do? You did this one, right? Focused GI assessment. That's a much better picture. Okay, and then here's your GI assessment: nausea or difficulty swallowing. Everything that you wrote down there. Biggest thing, pain. Where's it located? PQRST. Worse or better with eating. Everything that you wrote. And then here's the abdomen, the elimination part, the GI, any kind of bleeding right? Here's your patho. What is it? Okay? You have this barrier that's disrupted. So there's your tissue integrity. It's disrupted. Okay? So now you have signs and symptoms of that. It's disrupted because you have too much acid. Here's your pathophysiology, look at it. Here's your risk factors, look here. The acids, bile, salts, aspirin. Okay, how do you get acid in your stomach? You don't eat for a long time. You have like some burping, indigestion. What does somebody tell you to do? Did you eat? When was the last time you ate? What did you eat? Now, in this whole discussion, nobody said anything about diet. Is there any specific diet for a PUD? No.
Well, we have to worry about doing certain things to
Some,
relax the esophageal sphincter, and we're gonna get reflux.
yep, so I see that you've got some experience. All right, here,
20 years of GERD.
you have experience with GERD, okay? Yes. So you've got, but for peptic ulcer disease, and you're a culprit, I'm not pointing you out, I'm gonna, would I? Okay, you're pointing you out. She's got some issues with some sort of reflux. And why? Maybe the reflux, this LES, sphincter, is too relaxed. So it's called echolalia, okay? And that sphincter is too relaxed, so the ulcer goes, the acid goes back and forth like this. If you have an ulcer, you don't have to answer, no answering. If you had an ulcer, it would probably be here, okay? If you had an ulcer. The only way to know what's going on with this acid reflux, they probably put you on some medications first to quell the symptoms, PPIs, H2R receptors, antacids. Avoid foods that are irritating, and that's the peptic ulcer disease diet. Avoid foods that are irritating. If onions bother you, don't eat them. Okay, our small frequent meals, what? Small frequent meals, are they good for everybody? Absolutely. Small frequent meals. Avoid irritating foods. Now, certain foods are more, they make more acid production, caffeine, peppermint, I'm looking right, okay? It depends. Tomato juice, tomatoes, cooked versus non-cooked. But there's no, if you have to have a tangible answer, there's no specific diet for peptic ulcer disease. Avoid foods that are irritating for that person. Okay? That's it. That's like playing down the journey, okay? All right, so when you think about all of this, this is a wonderful, it makes you think about, look at the culprits, aspirin, NSAIDs, alcohol. Is alcohol or smoking, what do they do? When you drink, do you eat? Not really, you really don't eat. Good drinkers are not good eaters. I'm full. Okay, so good drinkers are not good eaters. So what do we have here? We have an irritant. All right, it can upset the stomach. Smoking, is smoking good for anybody?
No.
There's nowhere that you're gonna say, keep smoking, okay? Because it's good for you. It's not good for you, okay? Because physiologically it decreases blood flow to the area. And that's why it's not good here, because we need with tissue integrity, we need to get good blood flow to the area. So we wanna promote healing that way. All right, so here's a great map, okay? A great map, breakdown of the barrier, that mucosal barrier. Okay, acid, destruction. With the increased destruction, you have increased acid and pepsin release, which is HCl, okay? Further destruction until you get to the blood vessels where bleeding. Bleeding causes ulcerations, all right? Histamine, okay, same thing, histamine. Any type of histamine reaction is vasodilation and increased capillary permeability. That means the fluid is going into spaces it shouldn't go into. So anytime you have inflammation, that's what it means, no matter where it is. And with that, we have edema, swelling. Okay, so it's a great map to think about what is PUD. Here you wrote down, okay? Now, abdominal pain or no pain, it can be silent. Right, so there you go. Where's it located? What do you feel like? Dyspepsia, early satiety, fullness, bloating, gassing, burping. And then you can have, so here it is. You know, what does it feel like? You're doing the PQRST, wherever that is, PQRST, right there for pain. Right, it's very specific here, right? And then look at all the words, gnawing, how to describe it, that's the pain. Describe it. Is it, you know, like tell me where it's located, what does it feel like, when does it happen, all right? Gnawing, burning, aching, heartburn, regurg, okay, all right? There we go, look, there's regurg. All right, there's that regurg, that's what we're talking about. Where can it be, location, location? Look at where we're talking about. Most common here, gastric and duodenal. When you go to the esophageal, will be Professor Parada. Okay, gastric ulcerations will be in the esophagus. Okay? In the esophagus, or GI. And what do you think you're going to see with ulcerations in the esophagus? What do you think is going to be that presenting sign for this person? Blood. GI bleed. I'm spitting up blood. Heidi is going like this. Oh God, don't come near me with that blood. All right? Okay. All right. Stress ulcers, what do we give every patient in the hospital? Is every one of your patients on prophylactic H2RA receptor or protonics?
Yes.
Is every one of your patients, please look at your med list. You may not have to give it, please look at your med list. I see people shaking their head, stress ulcers. It's most likely with that person that's in the ICU, acute coronary care units. That's where you're going to see those stress ulcers develop. Or you have that NG tube in the place, the mechanical vent in place, okay? Because that person is under a great deal of stress, being hospitalized body. So that's what that means, okay? So I'm not going to talk about H. pylori risk factor, okay? Big one there. We talked about location. I didn't go too much about it, but look at these. You want to know the gastric ulcer is older person and there's higher mortality, look at this, because of the bleeding, a GI bleed, heat at emesis. Okay, location, all right, after eating. Gastric, okay, so is that person going to like food? No, because food is going to irritate them. Whereas the duodenal ulcer is your job really to diagnose one or the other, but you're aware there's different signs. You're just aware. Food is the duodenal ulcer's friend. Let me eat something. It always makes me feel better. That's what they said. Let me eat something. Or, oh, I can't. It doesn't make me feel good. That's what they said. So gastric, doesn't make me feel good. Duodenal, let me eat. So what is the gastric person? Thin. The duodenal may have more weight on it. Okay? I mean, those are just very simple. And where do you look? Duodenal, because duodenal here, so melena. Duodenal. It's got to travel. Ooh, it's got a long trip. Right? Or if you have a gastric ulcer that's located low, it's still a long trip. They're not vomiting blood, but it's a long trip to get out. And their H&H is lower, you see a trend. Why? Okay, but let's do an occult stool. You have a bleed somewhere. What drugs you want? Okay. Stress ulcers, H. pylori. Here we are. What causes it? It's contaminated food, oral or oral fecal route. Told you that. Okay, here's the nursing. Okay, good. I'm sorry for the size of that font. I tried one of those pictures that the program gave me, and I'm saying, only trying it once, that's it. But this one, it lives deep. I just wanted to show you the shape of this H. pylori, because it's a little spiral shape and it get caught, it swivels itself into the mucosa of the stomach. So if anybody has heartburn or dyspepsia for a long period, indigestion for a long period of time, you want to know, have you ever been tested for H. pylori? Very simple test, blood test, right, stool test. Other risk factors, NSAIDs, aspirin, other anti-inflammatories, okay? And how do we treat it with? And then lifestyle, do we ever tell people keep smoking? No. Do we ever tell people just drink coffee all day?
No.
Keep drinking? Okay? So all of those irritating foods, irritants you have to dismiss. Any questions? Yes?
Under the risk factors, it lists PPIs as a risk factor.
No, treatment. RX is treatment, sorry.
Oh, I see. Yeah,
Sorry.
sorry.
RX, sorry. That means treatment.
Yeah, no, I know. I meant that.
Does everybody understand that now? Treatment. Okay? All right. Other risk factors, GERD, we have that reflux. And what do? Everything that we've said. All right, and how do we treat it? These group of meds, very important. Those are your big meds right now. This Zollinger, very rare. It is a duodenal type of ulcer, and it is highly secreting HCl, all right? And what do we have here? Fatty, frothy stools, or steatorrhea, okay, Zollinger, fatty, frothy stools. You're going to see that because absorption is limited. I'm going to talk about steatorrhea when I talk about pancreatitis. So the nutrients are unable to be absorbed. Because that's small intestine, thinks about what it does, it absorbs the nutrients. So if you're not absorbing, it goes through and you have fatty, frothy, floating stools. Don't you see? They're fatty, frothy. Everybody poop after a very high fat meal, and the stools are floating. The kids are, I'm not going to ask you, don't raise your hand. Okay? But I love our little kids when they're small. Come see what I did. Right? So you're like a cat. I would say you're always like a cat. Look to see what you did and let me know. As small people, right, little children, we try to teach them. Let me see your poop. Does this tell a lot? Yeah, it does. You see the blood, just look at it. Right? So your little people, don't flush until mommy sees it. Or daddy. Okay? Don't flush. You want to see it. Right? It tells us a lot. So fatty, frothy, very rare. Okay, do we treat it the same way? Yes. Okay, and now they've had surgery to it. We're not talking about that. The surgery is, major abdominal surgery, right? And we're worried about the same thing, nutrition, right? Because now we're compromised. Okay, silent, the silent ones, they take lots. Look at polypharmacy, those are pictures. Look at my pictures, they tell pictures are worth 1,000 words with me. Okay, they're not just pretty pictures, they mean something, right? So, they're running, they're jogging. Oh, my joints hurt. My children, when we do hike, they always bring aspirin prophylactically in case I die on that mountain. Shove some aspirin down your throat. And I always pre-up by, I pre-up by taking 2 Tylenol or 2 Aleve, 2 Motrin before and after. Not complaining, I'm better than you. Okay. I am too. And circles running. All right, so we know it can be silent. So it's either pain or no pain. Right? All right, and often found, look at, they have difficulty there's indigestion, dysphagia, maybe some chest pain, weakness. If it's chest pain, what are we going to do? You know that. What are we gonna do? We're gonna rule it out. We're gonna send them for an EKG. So it's not cardiac, let's see this GI. Because this GI can cause chest pain. We need to rule out cardiac. That's the priority, right? All right. All right, so here we have stool guaiac, H&H. All right, so you're looking at all that. Pediatrics is treated the same way. With the meds, hold the baby up after feeding, wait till they birth. Okay? Don't feed the baby in a reclining position. All right, I gotta get going here, so we gotta pull up the code. All right, diagnostics. Look, urea breath test, stool guaiac, upper GI. Those are the very simple upper GI. What do we do for nursing instruction after upper GI with barium? What do we want to tell that person, upper GI? Upper GI, what do we want to do? Increase what? Fluids. What is their poop going to look like after barium? White. It's the barium coming out through them, the contrast. So it's going to be constipation issues, so maybe stool softeners. I won't discount it. Okay, so stool softeners after a barium, right? Are we going to be NPO after a barium, or NPO before a barium? Yeah. Okay. Right, so you're always thinking about dehydration, blood pressure, vital signs. Endoscopy with biopsy, most accurate. Okay, and here we look all the things that we can see. Look at this. IgG testing, antibodies, so we can do blood levels. They're checking blood levels for that Zollinger. Look at that one. CBC, we saw that diagnostic, low H&H, platelets, bleeding, electrolytes, right? All right, and we're looking at renal. Now here we come to the meds, all right? So you're concentrating on these meds, and you're thinking about who are they? I mean, what do they do? All right, here's the combination for H. pylori. What do you need to know about them? And we use a flagell sometimes. Whenever you see flagell, you know that it is a GI drug. It is best for anaerobic. The key word is anaerobic. What does anaerobic mean? Bacteria that grows without oxygen. And is our gut an anaerobic place? Yes. Okay, so with flagell, again, lots, know your meds, what are we taking it with, avoid it. So look to see, what are they taking? Anticoagulants are effective with it, please let the provider know. And look at adverse reactions. Pseudomembranous colitis, that means that person has a lot of diarrhea, which means a lot of, what kind of loss? Fluid loss. What are we worried about with fluid loss? Dehydration, which can lead to
Hypovolemic shock.
big complication. How do we know we're in hypovolemic shock?
Blood
Blood
pressure.
pressure low, heart rate high.
Okay? Use your vital signs. End of my story. Okay? Here's your drugs here. Proton pump inhibitor, it blocks. Okay? Give prior to meals. Don't chew, don't crush. Don't give with other meds, because multiple drug reactions. Give alone. Do we say that? Give alone, don't mix the meds, give prior to meals, give on an empty stomach. It all says the same thing, right? I've said it different ways, same stuff. Calcium, MAG levels, okay? It can decrease B12 levels, so you want to make sure that you're always checking H&H, because what are you thinking about? Bleeding, because you know what ulceration causes bleeding, okay? Or decreased tissue integrity, inflammation. This is what an ulcer, okay? This is what is ulcer, okay? So it's altered. All right, here's all the names of, okay, so we have the prazols, right? The prazols. And I think somebody said before here. Praise all, so there we go. Okay, so you guys are awesome. All right, so and then we have our next one, H2 RAs, reduces by-blocking histamine. Give alone, here we go, same thing, give alone, don't mix it with other drugs, that's what that means, right? Okay, side effects, ED. Here we have another drug that causes erectile dysfunction. I'm just putting it down because there's a lot of people on it and they're very conservative. Okay? So another med that you need to teach people on, all right? Vitamin B12 deficiency, gynecomastia, all right, B12, so or GI bleed. Well, we all take these meds to prevent GI bleed. These meds are used for prevention of all the complications of GI bleed because the ulcer is also in the ulcer tissue integrity is impaired with the ulceration. Antacid. Look at the key words. Neutralize. All right? They do not coat the ulcer. We have another drug that coats the ulcers. Okay? A mucosal barrier. We have other drugs that coat the ulcer. All right? But this one, antacids, we have different products with them, and we have side effects with them. So knowing if you're taking an antacid, what is it? What type is it? What other health problems do we have? If there's a renal problem, we want to avoid the mag and the aluminum. Okay, the magnesium products and the aluminum with renal. So what other problems does this person have? What kind of history do they have? Look at give alone, follow with water. You can follow with water. It's not mandatory, but you can follow. Can I drink something afterwards? Yes. Allow 1 to 2 hours before other meds. That means give alone. So I'm saying it different ways. So when you see things, give alone, allow 1 to 2 hours before other meds. That means give alone, right? Does that mean give alone? Yes. All right. All right, and then we have all the GI complications of either too much, like too much diarrhea or too much constipation. Right? So we're good. Here's all the names of them. Here's Rolaids, calcium, aluminum, magnesium. Okay, so you see all of them. Look at this, a mucosal barrier. So antacids neutralize, did I put that word down, neutralize?
Mm-hmm.
Yeah, neutralize. And what is this? These are barriers. So that means it covers the ulcer. Right? It's used in conjunction. All of these drugs are used in conjunction with each other. Okay? They're all used with each other. So look at this. Short term, 30 minutes prior to the meal. So guess what? You have to be aware when the tray comes up, you have to give it before they actually eat. Whereas antacids can be given after they eat. This one is a protective barrier. It's a barrier. Like a barrier that protects. Okay, you have to give it before meals, antacids after meals. All right, and here's another one, Pepto-Bismol. All right, and sucralfate is the one that you see. Pepto-Bismol you can buy over the counter. Okay, and it is. You have to read your labels. Avoid when you're teaching. Read the labels. Avoid aspirin products. And it's temporary relief. It's temporary relief. And it's Abisma subsalicylate. When you see salicylate, that is your key word for aspirin products. Aspirin products cause bleeding. So if you take this one, as a protection, you want to avoid other aspirin products. So you have to always read the label, avoid others. Here's a synthetic prostaglandin cytotec. We don't see it very often. I'm just telling you about it in case you hear it. It does cause miscarriages, so you always have to find out what they're using for. It's it's always used for patients using NSAIDs. Not commonly used, my job is to expose you to all the options, right? Did I spend any time on this one? No. Did I spend some time on these others? Yes. Just so you know. Prokinetics, Reglan, I'm not spending time on this, okay? Prokinetics, increases the motility. I'm not spending time on this, because I think this is like the first year med that you had. It causes dry mouth, sedation, you avoid it with Elgerol, okay? Am I spending time on that? No. Am I spending time on those other 4 categories? Complications. Bleeding, hemorrhage, perforation, or gastric outlet obstruction. So we talked a little bit about GI bleed. What is it? How do we recognize it? Okay, we recognize it with the vomiting, right? GI bleed, vomiting. And vomiting, I think GI bleed, we did write it down, but GI bleed. It can either be bright red blood or coffee ground vomitus. So you have to describe it. So this person is vomiting, oh my God, right? What do we do? What do we need to do?
Zofran?
Who said that? What do you want to do?
Zofran?
Zofran. Okay, but somebody has to go get the Zofran. I'm vomiting. What do you want me to do?
Sit
What do you want me to do? I'm sitting here. Get me a bucket?
Sit down.
What do you want to do with me? Sit down. Okay, so if you're coming in vomiting, you want to sit down, okay? Somebody go get me maybe some anti-nausea. Okay, then what are you interested in? I'm vomiting in the bucket. What are you interested in? Color, the amount,
If there's blood.
blood. Okay, all right. And then what are you going to ask me? When did it start? Okay, I'm vomiting and vomiting and vomiting. What do you want to do?
Check vitals.
Oh, I like that, girl. Fluids? Okay. What are you worried about?
Dehydration.
Yep, dehydration. And what do you want to do now? If somebody wants to get the Zofran, you sat me down. Bring my arm up for you.
Vital
Somebody
signs.
get some lines in.
Vital signs.
Oh. Got my vital signs, because what is that going to tell you? Am I hemodynamically stable? Meaning, what's my blood pressure? Is it too low? It's over here, right here. Okay? So I thought, okay, really struggling with the vomiting, what might you do for me? I have an ulcer, that's what I'm gonna get out of you. She got lines in, somebody went to get me Zofran, somebody gave me a bucket, amount, color, okay, what else? Somebody took my vital signs, so I got 2 lines in. All right, I have an ulcer. What do you think you want to give me? How do you treat an ulcer?
PPI.
PPI. So we're going to get some, there's an order for Protonics. Okay, so let's start with protonics, see if that, what's it gonna do, what does protonics do?
Blocks the release of acid.
A proton pump inhibitor, the pump pumps out HCl. Okay, so GI bleed, amount, color, all right, when did it start? So PQRS, where did it start? What is the cause of it? I do have an ulcer. You know, what are you gonna treat with? An NG, oh, the police have an NG2, did they? Am I making it up in my head?
Well, we did earlier.
Anybody want an NG tube? Yes, an NG tube, somebody did say it earlier, I have to look at it again from a distance. Okay, NG tube, okay? You want to, and I'm having pain too, right? Do you want pain meds or PPI? Because what's PPI going to do? Do that PPI, right? We'll see how this works, we'll get you, keep watching you, check that pain level, check the vomiting level. I'm always worried about hypovolemic shock. Okay, in complication with GI bleed. All of this is an emergent situation, okay? So all of this is an emergent situation. That means you've got to do something quickly in the first 24 hours. So here we go, nursing assessment. I want to make sure that you get what you need out of this whole thing, nursing assessment and interventions. So for PUD, what are you going to ask them first? Here's your nursing assessment. So what's our nursing assessment? If these are our signs and symptoms, what are you going to ask them?
What kind of pain?
Do you have pain? All right? Nursing assessment. For signs, do you have pain? Where is it? Okay, what else are you going to ask them?
What medic?
All of this, that PQR, I'm not going to write that down, because the onset, when did it start? Okay, what were you doing?
What medications they're on?
What is it?
What, oh, just the medications. Are you on a steroid, aspirin?
Oh, any kind of meds, right? Any meds. Because what are you thinking of? Okay, yeah. Are you on any aspirin, corticosteroids, NSAIDs? Okay? Do you have any? You're doing your focused GI assessment. Nausea, vomiting, diarrhea. I'm not going into the further pain thing, PQR. When did it start? How long? Does it radiate? Location? Right? Are you on any aspirin, NSAIDs, cardiac medication? Right? What are you going to ask them about the vomiting? Like, what are you interested in? Blood or dark, tarry. Okay? And then what are you going to ask them? If you have a low H&H, what are you going to ask them? Are you dizzy? Lightheaded, because we know it can be very silent, right? Lightheaded, dizzy, weak. Living conditions. Who do you live with? Who's in your family? I live at the homeless shelter. I don't have a home. So what are you thinking of?
Age PUD, right?
You're thinking living conditions are not up to par. You don't know what he's eating. He or she is eating. Okay, so you think about contaminated food. the street. I don't have a home. I live in a group home. Okay, so that tells you a lot, right? Okay, good. Nursing assessment, what are you gonna, and then past that assessment, what are you gonna teach them? So, you're discharging somebody with PUD, what are you gonna teach them? Report any what?
Any blood in your stool.
So report to your doctor anytime you have change in color of what? If you're vomiting, if you have blood in your vomit, report to your doctor if you have any kind of pain. Okay? Is there any change in that pain condition? All right? Read the labels. Okay, take your meds with food if you have to take those other meds. Okay, if you're smoking, try to stop. If you're drinking, try not to drink or, right? So smoking cessation, alcohol, irritating, avoid the irritating products. Okay, report any episodes of pain, bleeding, tarry stools, blood in your stools, any weakness or fatigue. Okay, make sure you know that. Questions?
For PUD, they don't have any specific diet.
No diet, we said that. Avoid the irritating foods. Avoid the irritating foods. Everybody has different irritating foods. Tomatoes, coffee, alcohol, coffee, M&Ms. I had a friend when we worked on the floor, all she drank was coffee, black, and M&Ms. She carried them in her pocket all day. That's what she ate for days, M&Ms and coffee. I kind of like that diet too. Well, you had indigestion really bad. Did she develop an ulcer? Yes. Okay. Let's just go through the complications, GI bleed, and we're looking upper GI bleed, and it can be visible or occult. All right, what causes GI bleeds here? Look, the peptic ulcer disease. Okay, that's number one. All of the others we can talk about because this erosive gastritis, the esophagus is eroded, you're spitting up blood. You gotta find the origin. You're focusing in on peptic ulcer disease. Mallory-Weiss syndrome is that excessive retching. Retching so bad that you tear something, okay? Cancers, but GI bleeds can be caused with peptic ulcer, multiple reasons. Esophageal varices, and that's Monica. There's esophageal varices or Monica right here. Esophageal varices. Okay, MP, we're putting Monica Parada's initials there. Can cause a GI bleeds. How do you have esophageal varices? Liver disease. So she'll talk about liver down the road. Okay, what is a GI bleed? Right? Tells you it is an emergent situation. There is a high mortality. If you have a gastric or a duodenal ulcer, which person has a higher risk of developing an upper GI bleed? Gastric or duodenal? Gastric. Makes sense just by anatomy. Right? Is there a high mortality? GI bleed? Because we're going into hypovolemic shock. You want to avoid that. What do?
Too large for.
IV sites, vital signs, okay? You've said it. Okay? Here's, again, pictures of where they are. These 3 slides tell you the same thing, but I like the pictures, I put them in. All right? So we're looking at duodenal ulcers, gastric ulcers are always a possibility with PUD that you develop a GI bleed or GI hemorrhage. You look at the pathophysiology, anywhere, okay, it's an erosion of the blood vessel, okay? What GI system, an erosion of the blood vessel. Can we bleed from the rectum? Yes. Do you think it comes from the esophagus? Okay, so location, location, location is key, all right? And what type of blood is it? Is it dark red or is it bright red? Are you, your job to say, you're worried about, yes, color. Is it bright red or is it darker red? You're worried about the amount, right? And they're vital signs. Big vital signs. Vital signs is what are you worried about the person going into with GI bleed is. And how do we know that we're going into hypovolemic shock?
Blood pressure and the heart rate.
And of course, all of the perfusion, mentation, peripheral pulses, but blood pressure and pulse, all right? Here we have this hematemesis versus coffee ground versus melanoma. Hemochromia, bright red or maroon stool. It's like a lump of, like a clot. So just terminology. ID the source. Manage the signs and symptoms. What are we managing? What do we want to have under control? What do we have? Want to have blood pressure and pulse. Blood pressure and heart rate. Am I repetitive?
Mm-hmm.
Blood pressure, vital signs. Blood pressure and heart rate. Blood pressure and heart rate. We want to ID the source, how much, but we want to monitor the vital signs. How do you think they're going to diagnose the diagnostics for a GI bleed? How are they going to visualize this GI bleed? What do you think they're going to do?
Endoscopy.
Endoscopy. Do you think they're going to do it when the person's really vomiting?
No.
No. They want to stabilize the person. How do you know the person is stabilized? What do you monitor?
Vital signs.
Because what are we worried about with the GI bleed?
Hypovolemic.
How do we know we have hypovolemic shock?
Blood pressure, heart rate.
High heart rate.
What do we monitor?
Vital signs.
We rarely, how do we treat an ulcer?
PPI.
And then
We rarely need surgery, so I'm talking very small about surgery. So clinical manifestations or signs and symptoms are written right here. GI bleed. You're vomiting, describe the color. You're pooping, describe the color. Now that's a lower bleed, okay? That's a lower bleed, but you assess for signs and symptoms of a decreased H&H, like having dizzy, right? But vital signs, look at that. And then all those signs of perfusion here. All signs of perfusion. How do we treat it? Look at it. ID the site, maintain hemodynamic stability. How do you maintain hemodynamic stability? Oh God, there's big letters here.
vital signs. Every 15.
Right? Protect the airway of vomiting. So what does that mean? What do you want to do? So if I'm laying down and I'm vomiting,
Sit them up.
Okay, protect the airway, lead them forward, make sure they don't aspirate, you want to avoid aspiration, right? Protect the airway. That's what that means, protect the airway, avoid aspiration, right? We want to monitor losing fluid. Why do we want to do ECG monitoring?
Because they're losing potassium,
When we're vomiting.
potassium, cardiac.
Electrolytes, renal, what are renal studies?
BUN,
And creatinine,
Creatinine.
good, all right, good. And why do we type in cross-match?
in case they need blood transfusion.
Blood products, okay. So here's our interventions, aggressive IV therapy, right? Too large, have you heard this before? Yes. Hypovolemic shock. Too large, you don't want to lose that one side. Too large for IV fluids, whether it's blood products or just plain old IV fluids. You're always monitoring lung sounds. Why?
Make sure they're
Person
not acid.
vomiting.
Want to make sure they're not acid.
How do you give fluid?
That's right. Overload, fluid overload.
Or aspiration.
You want to do that assessment, I know. Right, how much do they vomit? Nasogastric tube. Now, I said to visualize the blood, right? To decompress, that's what bloating, so why do we use an NG tube? Decompress it, or sometimes lavage. I don't see it done a lot, but what they do is, now the person's got an NG tube, they're not vomiting. Okay, an NG tube, they are bleeding, sometimes lavage. If you're stopping to bleed, what kind of water do you put in? Lavage, push in, pull out. Lavage, you're rinsing. So you may put some lavage with some water, but whatever they put in, they take out. How do you know, right? So I put in this much, it was obviously it's clear water, okay, and I took out the same amount, but it was bright red. I did it 3 times each hour and it became less pink. It became less red, it became more pink. Okay? And discuss, okay, that's it. Aggressive acid suppression. Look at how do we treat it? Often started prior to. So do you know this? This is big, right? Treatment, how else do we treat a bleed? So whether it's IV PPIs or sometimes we use other meds. Epinephrine, what do we know about epinephrine? It does this to blood vessels. Vasoconstricts. Octreotide, sandostatin, okay, that's also, it stops the bleeding. Or coagulation, electrocoagulation. But how do you visualize the bleed? What's this, the diagnostic? Endoscopy, that's right. How do you know if there's pathology or not? Endoscopy.
Biopsy.
Other ways they can do it is an arteriogram, but never with a high risk. So I want you to be aware, but I want you to focus on IV medications. What's most important to a GI bleed is you want to stabilize them. In order to stabilize, you want to always monitor vital signs. What does that mean? Hemodynamic stability. Okay, so here we go. Surgical last resort. Last. Now, put big letters, right? Capital. They're not responding to medical therapy. All right? So either we take a piece of the stomach out, a pyloroplasty, look at this, pyloric valve, a pyloroplasty. Okay, so they work on that. And when they do a pyloroplasty, they cut the vagus nerve that produces HCl acid. Because this PUD is excessive gastric acid, hydrochloric acid that eroded the vessel. We have tried all sorts of medical treatment for it, but everything, now this person has developed a complication, a GI bleed, all right? And now we have to do a pyloroplasty and suppress that acid from the vagus nerve. So a vagotomy is just a cutting of that vagus nerve. Complications of GI bleed, hypovolemic shock, and nursing interventions, what do you want to do?
Monitor vital signs, get those 2 IV sites.
What do you want to do for hypovolemic shock? Vital signs. IV, okay? IV vital signs. IV fluids. We want to type in cross match just in case. Monitor the vital signs. Okay? All right. Let's just go, our next slide, let's just do this one. Right here, look at this one. Admitted last night after vomiting bright red blood. has a history of GERD, so we have reflux there, hypertension, takes medication for both, but cannot provide names of either, right? How many of you know that? Nursing assessment includes, what are you gonna do for his nursing assessment, okay? So here's the nursing assessment, I basically wrote it down for you here. Ibuprofen, 1,600 grams every day for over a year for osteoarthritis. So what are we thinking about that?
GI bleed, definitely.
Ibuprofen,
Yes, very bad.
as an NSAIDs. What do we know about NSAIDs?
They can
The
cause
risk
GI
factor.
bleed.
Yep, at risk for. Vital signs, look at his vital signs.
Ooh,
And read the writing.
not good.
112, over 68, down from, so what do we know about that?
That's a big
Decreasing.
decrease.
Decrease, pretty significantly, don't you?
Yeah,
What about the heart rate?
elevated.
Elevated and respirated.
Respiratory rate? Alert and oriented times 3, has pale, dry skin,
He's
slightly
dehydrated.
distended abdomen, pain 5 out of 10, mid, so location, mid-epigastric, bowel sounds are positive, that's what that means, so positive. Has dry, pale skin.
He's anemic and dehydrated.
What's concerning? So which information is concerning? Now, I did hear that you had, which information is concerning? I'll go back. Which information is concerning? So going back, which one is concerning to you?
The blood pressure, the heart
Okay,
rate,
so the blood pressure and the heart rate.
the pale skin, and the dry,
Pale skin,
dry skin,
pale
and dry
skin,
skin.
distended.
Bless you.
How about this first paragraph here?
Vomiting, bright red blood,
Vomiting, bright red blood.
ibuprofen, 16.
Okay, so bright red blood, ibuprofen, blood pressure, heart rate. Pale skin. Anybody want to comment on the pale skin?
Well, that would, with the H and H, anemia.
What if it said pale moist skin? What's most concerning? Pale dry or pale moist?
Pale moist.
Pale moist, why?
Because they're diaphragm,
Remember gingerbread man?
yeah.
Perfusion is altered significantly with that biggest organ being compromised, right? So that's most concerning. What actions or interventions are most appropriate and how would you do it? Okay, so what do you want to do? What do you want to do with this person? You want to take vital signs? Absolutely. What else do you want to do? IV, type and cross match. Is he sitting up, lying down? He's vomiting right now. Oh, no, he didn't vomit, he vomited last night. What else do you want to ask him?
When it started,
Pain, okay, pain. You don't know how much he lost, right?
Feels lightheaded or dizzy.
Feel lightheaded or dizzy? Very good. The amount. What complications do you want to prevent? Hypovolemia shock. And which patient assessments would indicate the actions were effective? So if you put 2 IVs in, how do you know? And we infuse, what would happen?
Blood pressure will go up.
Blood pressure would come up,
heart rate would go down.
heart rate would come down. Okay, good.
Somebody mentioned labs, what about those labs?
Oh, see her over there.
White
H and
blood,
H,
white blood cell.
What are you gonna do with the labs after the interventions? We didn't talk anything about white blood cells other than the infection.
Right.
This person just has some vomiting.
Right.
Okay, bright red blood erosion, GI bleeding. What would happen to the labs if you give them fluids, would they go up with fluids or they come down with fluids? So you put like, tell me which one it is.
Well, the H&H, if you're dehydrated, it's gonna look like it's higher, and then once you give fluids, then it's gonna you're gonna see that it'll come down.
It looks like it's gonna come down because the H&H may further decrease, okay, because now you're adding red blood cells in a whole bunch of fluid. You just infused 2 liters of fluid, so you're diluting it. Okay, so the H&H may come down at that point, or will come down after you give fluid. You're diluting, okay, that amount. Okay, make it look normal right in the beginning, but then you're gonna always assess for, are you dizzy or lightheaded? What are your vital signs? What are your labs? What are the electrolytes? Okay, so patient problems with the GI bleed, where are they? What kind of problems do we have with the GI bleed? So that's a good.
Oh, we're talking about patients.
Fluid and electrolyte, right? Anyone else? Nausea, vomiting. What other problems do we have? Anything else? Fluid and electrolyte,
Impaired.
pain management,
And,
Somebody said
diet.
perfusion.
Yeah.
perfusion, as related to what?
Hypovolemic
Hypovolemic,
shock.
low blood pressure, high heart rate. So you can call it different things, right? Electrolyte, fluid, H&H related to fluid. Okay. What is it? Tissue integrity. Okay, tell me where that's related to what? So when you think about, remember we talked about the tissue integrity, we just talked about that tissue integrity, the ulceration. So that tissue integrity was broken. But we don't see the tissue integrity, unless we have like integrity of the mouth maybe, or excessive vomiting. We don't really see that, but your understanding was an ulceration.
So what about inflammation, so the
But other
H.
information.
pylori?
It could be, we don't know what the cause of the H. pylori could have had been the root of this ulceration, which then, if it wasn't taken care of, develops a complication of GI bleed. But just for GI bleed, we're talking about volume, right? Fluid and electrolyte loss. I have to read out of the other study, yeah.
Go back to this. This is what you have. This is what your problems are, right? What's abnormal in your assessment, and that's gonna drive your problem. That's what you have to fix first, right?
Okay. Let me just, only because I want to get in here, the goal is 5 ways to avoid bleeding, GI bleed. What are 5 ways? Tell me. Think about what our risk factors are. No NSAIDs.
Stop smoking.
Stop smoking.
Reduce stress.
Stop drinking. Decrease your stress. Check your medications, right? Check other drug interaction medications. We'll fill that one in. Okay, and then perforation, the ulcer, we'll talk more about perforation when I do diverticulitis. Let's just go over this. Penetrates the whole wall of the GI tract, okay? The contents of the GI, contents leak into your peritoneal cavity. Here's your clinical manifestations. What's outstanding about all of this information? Which one are you going to report when you're doing your GI assessment?
The sudden sharp abdominal pain.
Keywords. What are some key words in this paragraph?
Sudden, sharp
Sudden, sharp
pain.
abdominal pain.
Radiating to the back.
Can radiate to the back. It's dramatic. Sudden is dramatic to me. It's an acute onset. And then again, remember where we are.
What about,
What are we assessing? Are we still assessing the same thing? Is there nausea
right,
or vomiting associated with it?
Yeah.
What are their vital signs? Are the bowels decreased? But we're focusing in on that dramatic, sudden, sharp onset.
what about, this is more, the other was more maybe a localized pain, where this is saying, you know, it spreads over the entire abdomen?
And it's sudden,
Right.
sharp, acute onset. All right? We know that this is a complication, right? A perforation. Now, that ulcer has perforated. So here, what do we have? Peritonitis. So it perforated, the contents of the gut are spilling over into that whole peritoneal cavity. We're worried about infection. We're worried about infection with that. So we're thinking infection, WBC, okay? WBC, vital signs, right? Tachycardia, that heart rate, so they're vital signs that increase respiratory rate and decrease urine output. Itis, infection. Life-threatening, and you need, what's the biggest complication that we want to avoid? That's right, hypovolemic shock. I'm not going to ask you how do we know it's hypovolemic shock one more time, right? How do we know?
Blood
I don't
pressure,
know. Blood
heart rate.
pressure, low heart rate, up.
We repeated it 100 times, okay? So we're immediate interventions. If we're worried about, what are we gonna do? What do you need to do to avoid that complication of peritonitis? Now, if I'm lying down in bed, what are you going to do to stop that perforated duodenum from leaking up into the upper contents? We want to sit them up. That's right. In order to avoid hypovolemic shock, what are you gonna do?
2 IV
Two
sites.
IV fluids, vital signs. I put my arms out, vital, but 2 IV fluids, lungs. Right? We know this, IV fluids, we know why. Why do we do NG suction? Reduce the amount of any kind of bloating, okay? IV antibiotics,
Infection.
pain and continuous monitoring. Again, everything's been said. Here's our diagnostics. And we have surgical management and non-surgical management. And then there's this gastric outlet obstruction. There's that pylorus. Very little about this. If that pyloric valve there is obstructed, so where do you think the fluid is going to go? Or the fluid is going to go? So what are you going to see? Dark writing?
Projectile.
Projectile.
All right. And what do we need to do? We need to open up that pyloric valve. Problems and interventions. So what are some big problems with nutrition issues, fluid and electrolyte issues? Same thing. Unresponsive is surgical, and again, you listen to my lecture about this, you listen to my voice over. Any questions on these? Because I have one more thing for us to do. Oh, there's more.
It's like the commercial.
What to call the doctor? When are you gonna call the doctor?
Any changes in
Change in
vomiting?
pain.
Changing color.
Color of the stool, very good.
Lightheaded or dizzy?
Energy level,
He said lightheaded or dizzy.
like, okay, changes, lightheaded and dizzy. What else do you call the doctor? There's more, this is the one I want to get to, this will help you. Anything else, any questions? Change in pain, change in color of stool, any increased vomiting, pain that's radiating. Lightheaded or dizzy, when she, okay, all right, let's just go through this one, I think this will, bring it right up. Can I make this bigger, can you see this? Let's just read it. It talks about what peptic ulcer is, all right? So it talks about the whole thing, here's the objectives. Here's Mr. A.D. He's a 48-year-old business executive brought into the emergency department by a coworker. At work, he started vomiting a large amount of coffee ground emesis and requested to go to the hospital. Coffee ground emesis. Has a 9-year history of PUD, hospitalized with upper GI bleed 4 years ago. At that time, specimens obtained via endoscopy. And when he says he's recently been under much more stress than usual because of a company merger. He started smoking again after quit for 7 years, and his alcohol consumption in the last 3 months has increased, especially when meeting with other business executives. Because of his work demands, he's not taken his meds routinely, eaten a healthy diet, or slept well. Chronic or intermittent headaches. He's been careful not to use aspirin, but taking ibuprofen for headache relief. He reports he's been increasing dark stools for the past week and developed severe nausea before he started vomiting this morning. He has no sharp pain, only mild upper abdominal discomfort and nausea. Your initial assessment reveals the following. Blood pressure, 102/62, heart rate 98, respiratory rate 24, temp 98, cap refill 4, second, skin cool and slightly moist, no distension of jugular veins, clear lung sounds, and soft abdomen with hyperactive bowel sounds. Similar to some next-gen type of questioning, okay? During your assessment, you note risk factors in his history would include, associated with peptic ulcer disease, include alcohol use, H. pylori, NSAIDs, psychological stress, and what else would be a risk factor?
Smoking.
Type it in.
Smoking.
Smoking. You submit it, and it's blue. Right. Okay, next. All right, here we go. Duodenal or gastric. Again, we talked very little about it, but let's just think, if you can remember, think about location. Okay, aggravation with food, gastric. Okay, good. Associated with increased gastric acid secretion. Remember, we call that Zollinger. Duodenal. And increased gastric acid, think about that Zollinger. And that's duodenal. More likely to result in GI obstruction. Is it GI obstruction would be that pyloric, so where would it be? Is it GI obstruction? Let's try pyloric, so which one do you want me to do? This one, who says duodenal, who says gastric? Gastric? Associated with Zollinger, burning or cramping pain across the mid-epigastric. And if you read the thing, you would say duodenal. Burning or gaseous pain high in the would be where?
Gastric.
Gastric. Oh, wait a minute.
Oh my God.
Gastric. Greater incidence in women. Gastric. Higher mortality when perforation occurs. Associated with increased cancer risk. Occurring 2 to 5 hours after meals. Relieved with antacids and food. 35 to 45, younger. Did I miss one? Yes, I thought you said that. No. All right, let's just go through it. You were right. Okay, what's this one? As you finish the AD assessment, he vomits 460 mLs of dark coffee ground vomitus. The vomitus tests positive for blood. All right, select. So question number 1. You recognize that the appearance of this vomitus results from, pick one. Is it blood being changed to gastric secretions, fresh capillary bleeding in the stomach, or mixing of blood and fecal, or the presence of bile from the small intestines?
First one.
Fresh red?
No.
The first one.
Yeah.
This one?
Yeah.
Yes.
Correct. There you go, coffee ground. Oh, did I miss it? No, that's the next one. Okay, a static hemoglobin and hematocrit is ordered, IV fluids are started, a urinary catheter is inserted, and an NG tube is inserted and connected. Addition to low wall. Suction. Labs are ordered, the initial results are hemoglobin 14, hematocrit 42. You know that these results should increase as fluid replacement is continued, reflect to an equal loss of plasma and red blood cells, indicate he has not lost a significant amount, or are an indication for immediate transfusion. So get rid of the wrong ones. Do we want this one? No. So which one would you get rid of? Remember when what we said about that hemoglobin? The initial hematocrit may be normal, but then as you correct it, it's not indicative that that loss is significant until later on. So you do that baseline, now it's that equal dilution, okay? Here we go. Here's some, tying this up. Oh, my time is up. I thought it was 12:15.